All right, folks in Zoom land and folks in person, welcome. It's officially the noon hour. And this is our first child and adolescent psychiatry and behavioral sciences grand rounds of the season. So it's really a great pleasure to introduce Dr. Michael Bloch. He's an associate professor, and I'm going to list all of your titles. You are doing a tremendous amount of work. Associate professor, director, and co-founder, Pediatric Depression Clinic. Also co-director of the T32 Postdoctoral Research Fellowship in Childhood Neuropsychiatric Disorders. Associate program director of the Albert J. Solnit Integrated Training Program, and co-director of the Taken OCD program at the Child Study Center in the Yale School of Medicine. Dr. Bloch graduated from Yale School of Medicine and completed his child and adult psychiatry training at Yale. His research interests focus on developing better psychopharmacological treatments through clinical trials and meta-analyses. His research and clinical interests primarily focus on developing treatments for Tourette syndrome, OCD, ADHD, trichotillomania, as well as pediatric depression and anxiety. Dr. Bloch is also on the editorial boards of the Journal of Child Psychology and Psychiatry and the Journal of the American Academy of Child and Adolescent Psychiatry. It's quite an honor to have you here today. Please join me in a warm welcome. You can hear the clapping. I will mute myself and turn the mic over to you.
Thank you for having me. I guess there's nothing that's going to make me more uncomfortable than talking about all the things I've done. Big things I'm going to be talking to you about really treatment-resistant depression, and particularly ketamine, getting a few things out of the way. In terms of disclosures, these are my disclosures. The relevant research support is from the NIH for a R1 I'll talk about related to ketamine for treatment-resistant depression and suicidality, and Janssen's probably the other relevant disclosure, the makers of S-ketamine, that I'll also talk about in the talk. Really, the goals for this talk are, one, to talk about the burden of pediatric depression. Pediatric depression is a major public health problem, and if there's one thing you get out of the talk, I think it would be that. Talk about the current evidence-based treatments we have for pediatric depression, particularly the pharmacological treatments. To talk about what to do next in terms of pharmacological augmentation strategies for treatment-resistant depression, and then talk about why I'm interested in ketamine, at least the initial evidence on it. So if you get into what are the three leading causes of death in adolescents and young adults in the United States, it's one, accidental death, second is suicide, and third is homicide. Suicide is the second leading cause of death in this age group. And it's really, again, a major public health problem. And I, if there's one thing I think it's really important to get out of this is that I think is important is that that we start thinking about it like the source of significant morbidity and mortality that it is in our patients. In terms of suicide facts from the CDC in the United States, among high schoolers in the United States, 9th to 12th grade, 17% have considered attempting suicide in the last year. 14% have had a suicide plan. 8% have actually attempted. 3% have made a suicide attempt that required medical attention last year, and there are 5,500 deaths per year of adolescents who die by suicide. And this is Hamden High School, the high school that my kids will eventually go to in a few years. And that's 5 Hamden high schools worth of kids. I think the other important thing to say about me, not only am I a clinician and researcher, I'm also a father of 3 kids. So these are my family. This is my wife, Angie, and my 3 kids, Rachel and Paul and Sam, who were twins. So they were much younger in this picture. This is back when Paul and Sam were in preschool, but Rachel just started the 8th grade. And Sam and Paul are starting the 5th grade. So there's going to be 1 year that all 3 of my kids are going to be in high school together. And if you just take the numbers, as a father, I really think thinking about their collective risk there's basically a 50% chance that one of my three kids will have considered suicide in that 1 year they're in high school together. About a 40% chance that one of them will have a suicide plan. There's actually somewhere between a 1 in 4 and 1 in 5 chance that one of my kids will have actually attempted suicide in that 1 year. And there's, somewhere a little under a 10% chance that one of them will actually have required medical attention for a suicide attempt. And then I think the other thing to consider is that during their high school career, it's more likely than not that one of my kids will have a classmate who dies by suicide. And I think that's just something that I really worry about as a father. And I think that's important to keep in mind when we think about the scale of the problem. The other thing is we have quite effective treatments for pediatric depression. So this is the TADS trial, essentially 440 adolescents who were randomized for 12 weeks to either medication management just with fluoxetine and SSRI, DBT, the combination or both, or placebo. Bottom line in the trial, combination therapy was better than either monotherapy in terms of response rate. And that the other big thing was both meds and CBT were better than placebo. There was some evidence that the meds did better in this trial, but that largely washed out at later time points. So the bottom line is we have two really effective first-line treatments for depression, medication management, mainly with SSRIs, and cognitive behavioral therapy. If you look at the treatment guidelines, the U.S. treatment guidelines and the U.K. treatment guidelines differ somewhat. Both suggest basically supportive psychotherapy or brief psychotherapy for mild depression. And this is because a lot of the kids in the trials, there's a pretty high response rate to placebo in these trials, that the kids who have mild depression are very likely to get better over the short term. Certainly a treatment with less side effects makes more sense for mild depression. For moderate to severe depression, the guidelines differ in that the U.S. is evidence-based psychotherapy and or fluoxetine and SSRI. And then in the UK, it's psychotherapy plus minus medications or fluoxetine. So in the US, it's you can do either psychotherapy or medications. In the UK, it's psychotherapy plus minus medications. And I guess I'm kind of more of a Tory on this than anything else, just because there's pretty little side effects to doing psychotherapy. When you're starting a kid on medication for depression, you need to watch them closely anyway. You might as well be doing something while you're watching them. And I guess that's a big thing on this. I sometimes wonder whether our guidelines are more influenced by the ability to access psychotherapy and whether that's driving some of the U.S. guidelines. But that's my own personal opinion. In terms of antidepressants 101, when I'm giving my sort of basic psychopharm lecture to the residents or the child psychology or psychiatry psychology fellows at the Child Study Center, I analogize antidepressant medicines to being like the soda aisle in the supermarket. So that there's sort of this illusion of choice. So if you look at the local Walmart down the street on Fox and Boulevard in New Haven, there are 327 different kinds of soda that you can purchase in the soda aisle at the local Walmart. That being said, there are only a couple different kinds of soda. So like people either buy diet or regular soda, and they probably buy cola, or they buy, a fruit flavored soda, or they buy like root beer or something like that. The bottom line is, it looks like there's a lot of choice, but there's actually 327 varieties that are basically made by three manufacturers: Coke, Pepsi, Dr. Pepper, and that's about 90+% of the soda market. Bottom line is, there's sort of this illusion of choice that there are a bunch of different colas you can get, but if you like one, you're probably going to like all of them. And they're more similar than they are different. And I think the same thing's kind of true about our kind of antidepressants at the moment, that they really, most or almost all the medicines that we have really work by increasing some combination of the monoamine neurotransmitters at the level of the synapse. Either it's the SSRIs that are mainly just serotonin, the SNRIs or the tricyclics that are serotonin and norepinephrine, the MAOIs or some other antidepressants that add in dopamine. And that many of the medicines that we have for depression are much more similar than they are different. And I think that's important to keep in mind, that we have this, 30-something medications for adults that have an indication for depression. The vast majority are working under similar mechanisms. And just like we have this illusion of choice of soda in the supermarkets because Coke, Pepsi, and everyone else doesn't want me to come along with my new soda and steal some market share because people like to switch. There's this illusion of choice with these medicines, largely because the patent life of medicine expires. So it's a much better bet to come up with another medicine that works under the same mechanism and try to increase market share for that than to try something under a new mechanism that has a lot greater chance of not working. So there's sort of this illusion of choice. Antidepressants in kids, it's clear that the antidepressants work, and they work for a number of things. So we know SSRIs, selective serotonin reuptake inhibitors, work for depression. They work for OCD and anxiety. The absolute risk difference is higher, so they work kind of better for anxiety and OCD, and the number needed to treat is lower than they do for depression. But it's clear that these medicines work for depression. And if anything, in the sort of better done, more rigorous academic trials with fewer sites, the signal for the antidepressants, even in depression, is larger. So there's pretty good data that SSRIs work for depression, and even though one of the issues is they take a while to work. So it typically takes a couple months before you see the full benefit of antidepressant medicines, particularly SSRIs. That being said, in kids, the data suggests that the greatest incremental benefit you see in these medicines is early on in treatment. So they have a logarithmic curve. That being said, it really takes 6-8 weeks minimum to sort of accept that a medicine might not be helpful for a kid. And it's probably longer. It's probably 6 to 8 weeks if you're dosing the medicines like they do in clinical trials. From what I've seen in clinical practice, the doses are often lower and the titration is slower. So it may be even longer before you can kind of give these medicines last rites. The other thing to talk about is I think a lot of people talk about the risk of suicidality on the antidepressant medicines in kids, and that's largely based on the FDA warning, which was actually based on a meta-analysis of about of all the randomized placebo-controlled trials of antidepressants that were done in kids up till this point. It was probably 2004. There haven't been super many more since then. Comparing antidepressant medicines to placebo in pediatric populations. There were 4,400 pediatric patients, and showed a small but significant increased risk of spontaneously reported suicidal thoughts or actions in the trial. And the risk ratio was slightly less than 2. So you're twice as likely to report suicidal ideation on the antidepressant medicines compared to placebo. That being said, I think it's important to recognize that the absolute risk of this was quite small. The risk was 1% in the placebo group and about 2% in the antidepressant group of reporting increased suicidal ideation. So the number need to harm was around 100. So you need to treat 100 pediatric patients with an antidepressant for one to report that they had increased suicidal ideation. So the absolute risk was small, even if you accept the sort of the primary FDA headline as gospel. That being said, when they looked at the individual's suicidal ideation items from the depression rating scales in these trials, there was no signal. So that there was no significant difference between antidepressants and placebos. If you asked all the kids in the trial how their suicidal ideation was, there was also no completed suicides in the trial, and so I certainly feel like the warning is quite overstated. This is the best pharmacological treatment we currently have for depression, anxiety, OCD in kids. It showed some signal on some, but not all measures of suicidality. And I think lastly, I'm at least worried about how good a proxy suicidal ideation is for what we really care about, which is attempted and completed suicide, which really didn't have the same signal in these trials. I feel like the vast majority of adolescents who are depressed have some degree of suicidal ideation, and it's really a matter of degree in the kids that are coming to see me rather than a yes or a no thing. And the number that have them is very, very high. And then just to finish up about the risk of suicidal ideation, seem to be more in shorter acting antidepressants and longer acting antidepressants. And certainly the SNRIs, if anything, venlafaxine showed a worse risk than the SSRIs. And then just to say that that the benefit on anxiety and OCD is greater, and the risk of this suicidal ideation is less in anxiety and OCD compared to depression. And just to look at these numbers another way, this is something called the Cates plot. Each face represents one of 1,000 kids you're going to start with. You're going to start with an antidepressant medicine. The faces labeled in shaded in green are kids who are going to get better no matter how you treat them. The ones in yellow got better in terms of their depression, had a response because of the medicine. The ones in gray would have had suicidal ideation no matter whether you put them on a medicine or not. And then the ones in red had treatment emergent suicidal ideation related to the medicine. And this is what you'd see in MDD. And the big thing is there are a lot more kids in yellow than are in red. And so that's the thing with depression. If you start to look at anxiety, same things represented. The number in the kids in yellow versus the kids in red are much greater. So it has a better benefit to risk profile, and the same kind of thing in OCD. So the big thing I say about the black box warnings with families is that the SSRIs are the most effective treatment we have for kids with depression, OCD, anxiety. The FDA demonstrated increased risk of reported suicidal ideation in short-term trials of antidepressants, so they put a warning on the medicine. That being said, they didn't see it on all measurements of suicidal ideation, especially in the ones that were done systematically. And it's really unclear how good of a proxy this self-reported suicidality is for attempted and completed suicide. And what's clear as the reporting is variable in these trials. And that if anything, the epidemiologic study, the larger body of evidence suggests that the SSRIs certainly have an antidepressant effect, but also may have decreased the rates of suicide. And I say the big thing the warning says is not that you shouldn't take these medicines, but that the kids should be watched closely when they start medication. And I think the kids should be watched closely when they have significant depression and you're initiating treatment anyway. And so that Those are the big things. So what are the issues with the antidepressants? So I've talked about a number of them. The first ones, they take a long time to work, or I would say it's probably better to say they take a long time to not work. So it's really 2 months before I can say a kid who comes in with depression that I start on a medicine, if they're not going to get better, it's really 2 months before I know they're not going to get better. And then they don't work for not most patients, but a large number of patients. And if the initial medicine doesn't work, the other available medicines we commonly use, at least as sort of other first-line treatments or other antidepressants, work on very similar mechanisms. Then there are a lot of unanswered questions in the antidepressant trials in kids. I'm still amazed that there are no fixed dose trials of antidepressants in children, comparing whether 20 milligrams of fluoxetine works better or worse than 40 or 60 or 80 milligrams of fluoxetine. We have those trials in adults. The difference isn't dramatic, but we don't really have those trials in kids. There are really not many trials head-to-head of different medicines, and the data is particularly poor in younger children. Even though many times the indication includes younger, kids 6 to 12 on the medication label, the vast majority of kids who are enrolled in these studies are actually adolescents. And so the data on younger kids is less. So this is part of the reason why. So this is a graph looking at the number of randomized controlled trials of antidepressants on clinicaltrials.gov. The column in the far left is the number of adult trials. The black column on the right are the number of trials in kids, and there are much less trials done in kids than adults. And then you get a situation like this. So this is the number of approved FDA medications for the treatment of major depression in children versus adults. And so if you're including interventional therapies, augmentation therapies, and monotherapies in adults, they're now, at least the last time I checked, they're a little over 30. 32, I think was the number I had, whereas in kids there are 2. And that's escitalopram and fluoxetine are the ones that have FDA approved indication in kids. So there are less trials done in kids, and therefore we have less approved treatments. It's not rocket science. In terms of starting to talk about what happens if I'm going to start talking about treatment-resistant depression and thinking about that. When I'm talking about treatment-resistant depression, I essentially mean a child who has not responded to treatment with an evidence-based psychotherapy, an antidepressant of adequate dose and duration, mainly fluoxetine, escitalopram, or sertraline. And in treatment-refractory depression, it's having not responded to evidence-based psychotherapy and at least 2 antidepressant agents and at least one that has grade A evidence in kids. So at least one of fluoxetine, escitalopram, and sertraline. In thinking about starting to treat and evaluate kids with treatment-resistant or refractory depression, 2 main things that are important. First is, have they actually gotten the treatments that we know work? And the second is, do they actually have a diagnosis of depression? So when I'm doing evaluation of these kids, making sure with, getting pharmacy records, making sure that they've been on an SSRI and they've been at an adequate dose and they've taken it for at least a couple of months. The other thing I do is I typically check pharmacy records so I can look at refill intervals of the medication, because I think another thing is the medication doesn't work if you don't take it. And you'd be surprised at how many kids I'm evaluating for treatment-resistant or treatment-refractory depression that are getting their monthly refills of fluoxetine every 2 months. That's a problem. And it's certainly a problem that you address differently than giving the kid ketamine. Obviously, the ketamine is probably not going to be the treatment of choice we'd have for a kid who hasn't done the initial treatments. That involves, getting a pill box, finding out what are the issues with access, what are the barriers to treatment, working on adherence. The other thing is just seeing what treatments kids have actually gotten in therapy, where they're actually going, whether the parents are involved. And I think that's really important. So if they do have treatment refractory depression, one thing to think about is always figuring out, can I maximize or change the psychotherapeutic treatment they're getting? And then the other options, we'll talk about medication switches, augmentation strategies, and then we'll talk lastly about some interventional techniques. Really, the only, I would say, the only kind of real trial we have of medications in treatment-resistant depression in adolescents was the Tordia trial. It was 334 adolescents with depression who had failed, who had not responded adequately to 2 months of treatment with an SSRI, and they were essentially randomized either to get a new SSRI or an SNRI, venlafaxine, and they were randomized to either getting cognitive behavioral therapy or not. Bottom line of Tordia was the highest response rates were in the kids who got CBT, regardless of which other medication they got added on, either an SSRI or an SNRI. The second SSRI and the SNRI, venlafaxine, had similar response rate. That being said, the SNRI had a greater side effect burden, and that was mainly increases in blood pressure and heart rate in the trial. So in general, we use I use a second SSRI over an SNRI when I'm doing a second trial. And so again, Tordia suggests switch to a different SSRI rather than an SNRI because of side effects. And then there are a lot of, I'm not going to talk super much about all the failed trials in kids of medications that have worked in adults, but there are a lot of medicines that we know are effective for depression in adults that have not shown efficacy in randomized controlled trials of kids. Venlafaxine, PCAs, vortioxetine, and then there are many other medicines that have not been super well studied in kids. And so you have a situation where there are a lot of medicines that we're using in kids now where we don't really know how effective it is, or that's been demonstrated to be not effective in randomized controlled trials. That being said, there are a lot of issues with the current trials of a lot of the antidepressant medication in kids, and it would be great to ask me about it as a question later on, because I have a lot of thoughts about that. Sometimes I wonder a lot whether a lot of the medicines that have failed trials in kids really don't work. And there are reasons to suspect that they may work better than we think. If you look at augmentation things, so these are medicines that I commonly use as augmentation strategies in the adults I see with treatment refractory depression and in a lot of times in the kids. And so the big things is they have odds ratios of response somewhere in adults of somewhere between, 1.2 and 1.8 in adults. Number needs to treat somewhere between 7 and 40 in trials, usually 7 and 20. And the big things is that a lot of these agents have fairly good evidence, grade A level evidence, evidence of efficacy in randomized controlled trials or meta-analyses of randomized controlled trials. At least more than one randomized controlled trial and a meta-analysis is grade A evidence. Whereas in pediatric populations, all these things that we're using have grade D evidence. So they are based on expert experience, expert opinion, clinical experience, or extrapolation from adult data. That's why we're using them. And so really, it's a problem that we don't have trials to assess whether these medicines really work or not in kids, because at least I'm using them a lot, and a lot of the people around me are using them a lot. One strategy that I see really used a lot in both kids and adults is antipsychotic augmentation. And these are the results of a network meta-analysis using various antipsychotic augmentation for mood disorders. And the blue squares are talking about the effect sizes of the antidepressants compared to placebo or other interventions. And the big things is that this only has a small to at most moderate effect size. So it has an effect size of somewhere between 0.2 and 0.4, which is small. So it works, but at the same time, these medicines have a lot of side effects in adults, let alone kids, and they don't work. They don't work great, and so the current augmentation strategies in adults with depression, and in addition to being a father, I'm a tortured Mets and Jets fan, so the color scheme you'll notice is usually blue and orange. But the big thing to stay on the left in blue is the odds ratio of response of these augmentation strategies in adults, and most of them are demonstrated to work and work decently, but none has an odds ratio over 2. And by and large, they take a long time to work. So we're talking on the order of a couple weeks to a couple months in terms of the medicines reaching the full effect in the trials. So that's the current lay of the land. And if we're talking specifically about kids' treatments, what we know is SSRIs are an effective treatment for moderate to severe depression. Psychotherapies are effective for children with depression across the board and are always a good treatment option. And as I'm taking off medications, thinking about some of the interventional strategies I'll talk about later, always going back to psychotherapies makes sense. Second, SSRI is likely a better treatment option than an SNRI. And the other things we know is a sizable proportion of children and adolescents with depression don't respond to first-line treatments, and too many die from depression or die from suicide. What we don't know is really sort of major questions as a clinician that I wish I knew in treating pediatric depression. Do higher doses of SSRIs work better than lower doses? How does slowing down the titration improve the tolerability and efficacy of SSRI medications? What should you actually do in a kid who is experiencing suicidality after they start an antidepressant? What's a time frame where treatment emergent suicidality is most likely to occur? What's the best course of treatment on a kid who reports increased suicidal ideation a month after starting an antidepressant medicine? Should I keep them on the medicine? Should I discontinue it? We don't really know the answer to that. What are the risks of discontinuing an antidepressant in a child who responds to initial treatment with depression? When should we consider discontinuing? What augmentation strategies that are commonly utilized in adults actually work in kids? Don't really know the answer to any of those. And then those are really obviously important questions in the field. I'll just point you to an article that Jenny Dwyer wrote with me that was in JCPP a few years ago, where we did a staging model of how we think about treatment-resistant depression across stages in kids. So now getting into the stuff that I'm starting to think about and why I'm interested in it. So I'm very interested in looking at ketamine. Ketamine is traditionally used in medicine as a dissociative anesthetic. It's a non-competitive NMDA antagonist. It's mostly used in anesthetic or sometimes as a drug of abuse. As a treatment for depression, it's given at a dose of 0.5 milligrams over 40 minutes. So it's given at a much lower dose, and it's given in anesthesia and given over a much longer period of time. And if you were thinking about, people who are using ketamine to get high, they typically take the dose we give over 40 minutes, and they take it as a bolus, either intranasally, orally, or IV. In terms of ketamine's effect in depression, so the first study of ketamine as an antidepressant was actually done at Yale, and it compared ketamine to saline, and it showed a dramatic antidepressant effect that started around 3 to 4 hours after an initial dose of ketamine, and then was really observed to last up into 72 hours. So as traditional antidepressants are really taking typically 8 weeks to reach full effects, ketamine's happening, really quickly. So on the order of hours to days. And so that's what made it interesting to look at. I would say that just to be clear, the benefits of ketamine on depression are typically seen 3 to 4 hours after, whereas some of the dissociative side effects and other symptoms you see of ketamine have typically dissipated by 2 hours afterwards. Typically peak about 40 minutes right at the end of the middle, about 20 to 40 minutes after you start the infusion, and start subsiding about 60 to 90 minutes after you start the infusion, or 20 to 45 minutes after you stop it. So there have been a number of trials that replicated this result. The odds ratio of response to ketamine rather than a control condition, either midazolam or saline, was 10 at 1 day after the treatment for ketamine. And even a week after one treatment, the odds ratio of response was 5. It was a little less than 5 in the trials. So that's quite large. We've also, I did a meta-analysis with Sam Wilkinson and Jerry Sanacora, looking at the individual patient data of the ketamine depression trials and looking at the effects on the individual suicide items in trials. And there's actually evidence to show that ketamine has a substantial effect on suicidal ideation that's is also statistically significant and significant even if you control for the other improvement in the other depressive symptoms. And it has an effect size of 0.7 to 0.9, depending on where you're looking at in the course of the first 7 days of response, larger at the beginning, smaller at the end. And it had a number needed to treat in terms of being free of suicidal ideation of somewhere between 3 and 5. So you were much likely to be without suicidal ideation if you got treated with ketamine than if you were treated with a control condition if you had it to begin with. And in terms of thinking about interventional strategies in kids and why I'm interested in them, I took the same blue and orange graph. I put some of the interventional techniques we use in adults in terms of the odds ratio of response and the time course to effect. The reason I'm interested in ketamine in pediatric patients, long story short, is ketamine in adults is shown to have a larger effect size than a lot of the augmentation strategies we're using for treatment refractory depression, and it works faster. So I think you put together the two big parts of my talk so far. Depression is a big public health problem in kids, and ketamine is a very effective intervention. That's why we started looking at ketamine. So the first trial we did was looking at whether a single dose of ketamine was safe and effective for adolescents with treatment-resistant depression. I did this study with Jenny Dwyer. It was funded by ACAP's pilot grant at the Child Study Center and the Thrasher Foundation. We took adolescents 13 to 17, had to have a primary diagnosis of major depression, had to have severe depression, had to have at least treatment-resistant depression, having failed at least one prior antidepressant trial. Vast majority were treatment refractory. They had to be on stable medicines. Given that placebo response is an issue in all depression trials, we used midazolam as an active control, which mimics some of the side effects of ketamine. We had separate efficacy and safety raters. So the people who looked at the side effects of the medicine, the people who graded that in the first couple hours after the infusion were different from the people who looked at efficacy later. They were actually in two completely different places. So the efficacy ratings were done at the Child Study Center, and the infusions were done at Yale New Haven Hospital. So this was a crossover study involving these 17 kids. You got a medication on day 0, and whatever you didn't get on day 0, you got on day 14, either ketamine or midazolam. After the initial IV infusion, we did ratings of side effects, and we're monitoring heart rate and blood pressure for the first 3 hours after infusion. And then we did a bunch of clinical ratings to basically assess how you were doing in terms of depression and other symptoms at various points during the first 2 weeks following the infusion. In terms of the sample characteristics, very similar to what we see in clinic, primarily, predominantly female, quite depressed. The other big thing about this sample is they've been depressed for a really long time. So they had an average duration of their current depressive episode of 21 months before they enrolled in this trial. And they tried an average of three antidepressant trials before they enrolled in terms of their current episode. In terms of the findings, this is probably the major take-home point. At day 1 following infusion, in terms of the MADRS ratings, there was a significant benefit of ketamine compared to placebo, about a 9-point reduction on the MADRS, and the effect size was about 0.75 in the trial. So fairly large effect. If you're looking at the time course of response, the kids showed a benefit all the way out to 14 days after the single dose of ketamine at many of the time points. And if you're looking at what that means in terms of response, having a greater than 50% improvement in your depressive symptoms at any point during the first 3 days following the infusion, you had this situation where 13 of the 17 adolescents responded to ketamine, 6 responded to the placebo midazolam, and 5 responded to both treatments, and 8 responded just to the ketamine, and 1 responded just to the midazolam. And so that was a statistically significant difference. And so at least the single dose study is very similar to what in adolescents is very similar to what's seen in the adult literature in terms of the magnitude of the effect, and then also the significant benefit. If you looked at who was more likely to respond to the treatments, this hasn't been published yet. In terms of responding to the control condition, you were more likely to respond to the midazolam if you had less severe depression at baseline, if you had a less severe MADRS score. In terms of the responding to the ketamine, you were more likely to respond to ketamine if you had a shorter duration of your initial depressive episode, if you had a fewer number of previous antidepressant trials, previous number of augmentation trials. You were also more likely to respond if you were currently on an SSRI compared to an SNRI or another antidepressant. What's probably going on there is the longer you had the current episode, the less likely you respond to any treatment. And that the stuff you're getting in which medicine you're on at the moment is probably highly correlated to how long you've been depressed. Someone like me wouldn't start an SNRI until you'd failed 2 SSRI trials first, so you were less likely to be on that. If you looked at moderators of treatment improvement in terms of who is likely to respond to the ketamine treatment, again, it's the same kind of things. Fewer number of past trials, fewer number of previous antidepressant therapies meant you were likely to have a bigger improvement on ketamine. That being said, we also looked at the side effects of the treatment. So if you're looking at kind of the dissociative side effects of treatment, It's very similar to adults. You saw quite significant dissociative side effects at 1 hour after the treatment that dissipated by 2 hours. And that typically involved things like people reporting that they were feeling spaced out, that they felt disconnected from their own body, sometimes temporal or sensory differences, like feeling like parts of your body were big or small, things were moving in slow motion. That being said, there was no correlation between the degree of dissociative symptoms that kids had in the infusions and whether they were likely to respond or not. So basically, the responders and non-responders had similar scores on the CADS at 60 minutes after infusion, and it was not correlated with the percent improvement on the MADRS. The other thing you worry about in ketamine is cardiovascular side effects. So this is a reason why adults are closely monitored when they get the treatment. We did see a significant increase in heart rate and blood pressure with ketamine. That being said, it was much less clinically meaningful than it was in adults. We only had 4 patients, adolescents, at any point in the study that had any blood pressure reading at any point greater than 140/90, and none had one that I do not know how to shut off the volume on my watch, but I'll work on it. Hopefully people didn't hear the phone ring. Anyway, none of them had blood pressure abnormalities that persisted after the infusion, and none exceeded even 150/95. In terms of ketamine metabolites, we did see an association between some of the ketamine metabolites and treatment response. And I'm going to make this quick so we have time for questions. Big thing we saw was this hydroxynorketamine levels at 120 minutes was correlated with treatment response, and basically higher levels were associated with less treatment response. And what we think's going on is that that if you're metabolizing the ketamine faster, you were less likely to get better. And I have a bunch of slides kind of explaining why, which I will not go into too much. Bottom line from this trial is ketamine had rapid antidepressant effects in the single crossover dose trial. The effects were short-lived, and it was well tolerated in adolescents. Big future direction questions is, are repeated doses effective as antidepressant effects like they are in adults? Does it have anti-suicidal properties? What's the safety of repeated doses of ketamine or its sister molecule, S-ketamine? And could ketamine be effective for other conditions like PTSD or anxiety in kids and adults? So suicidal ideation is something that we've particularly been looking at as for these types of medicines as an indication. I call it one of the great conspiracies of psychiatry that inpatient hospitalizations last a week typically for depression, and it takes the medicines a lot longer than that to work. And it's not surprising that most attempted and completed suicides after someone's psychiatrically hospitalized occurs soon after their discharge, about 25% in the first week, 50% in the first month. And if you look at at Yale, if you look at the adolescent unit, very similar numbers in terms of attempts. And then the other thing is half the kids on our inpatient psychiatric unit for adolescents at any one time who are coming in with depression or suicidality had been there in the past 6 months. So we're also really, the kids with treatment refractory depression are really kind of sticking around the system. So this was, again, the meta-analysis that showed that ketamine had some independent effects on suicidal ideation. So there's actually been recently results of a repeated dose S-ketamine study. So S-ketamine is an intranasal formulation of the left-handed isomer of ketamine that's approved in adults for this indication. So this is adolescents with depression and acute suicidal ideation. They were given standard of care treatment after they were hospitalized. So medication change plus psychotherapy. In addition, they were randomized to either midazolam or one of 3 doses of esketamine, and they were given treatments twice a week for 4 weeks. Primary endpoint was day 1 depression ratings, and the bottom line was that the esketamine, this hasn't been published yet, separated from placebo in the trial. So there's a significant benefit of the of esketamine compared to placebo at day 1 on the depression measures. Did not meet endpoints on the measures of CGI for suicidal ideation. And I should say that the effects of the benefits of esketamine for both the suicidality and the depressive symptoms was a wash by 25 days. And so what's probably happening is that the other treatments, the evidence-based medication and the therapies are catching up. So you didn't see a significant difference at 25 days. So by 4 weeks after they got the initial treatments. We're also doing a study at the moment that's ongoing, looking at the efficacy of repeated doses of IV ketamine, 2 doses twice a week compared to midazolam in adolescents with treatment-resistant depression and suicidal ideation. We're also looking at MRI measures, fMRI measures, looking at to see whether we can predict who gets better and who doesn't. And then we're also looking at the third aim is to look at the durability of the response to repeated ketamine treatments. And so this is ongoing. And just in terms of looking at this design, the kids have to have treatment-resistant depression, severe depression, have a suicide event in the previous 120 days, and they're randomized to either get 4 doses of ketamine or midazolam under double-blind conditions. Then we do all the ratings to rate their symptom improvement, lock the database. Then we unblind the trial, and the kids who got midazolam and didn't respond then get 4 doses of ketamine. And then everyone gets treatment for the next 4 months with evidence-based medication management and cognitive behavioral therapy. And so we're also looking at the relapse rates. In the Janssen study, the relapse rates in terms of after you stop ketamine were quite low. So I think that's good news. Don't think that data is publicly available yet, but that's basically what it's going to show is surprisingly a large number of kids did not need repeated doses and maintenance treatment with ketamine. So I think that's it. These are 2 papers that talk about the results. I went 3 minutes over what I was supposed to, so I already broke my cardinal rule, and looking forward to your questions.
That was a fantastic talk. I also want to highlight the personal touch you took at the very beginning of your talk. It was much appreciated. It really brings home that this is value-based research, and it's highly meaningful, and we're trying to save lives. And I also appreciate your dry humor about the soda aisle. I do appreciate that. So thank you so much. We do have a couple questions in the chat. And I have a very overarching question related to the last comment you made regarding relapse rates. And so actually, you know what, I'm going to take a step back. My other question originally at the very beginning of your talk was around, could we consider using ketamine as like an emergency medicine that someone comes to the ED with suicidality? Is there a place for it to be prescribed in that way?
So I think so. I guess you're asking a question that I'm very ambivalent on. So I think there are kids that are really depressed. We have this crisis of kids showing up at the emergency room. I think my sense from the data is in adults or kids, giving an infusion or a dose of ketamine would probably be very effective at temporarily improving their depression and suicidal ideation. I worry a lot about in our healthcare system about what's going to happen to those people after they get discharged. from the emergency room and whether they're really going to get either the repeated treatment they need in terms of medication management therapy, additional doses of ketamine, because I kind of told you there's a little better than 50% chance that someone's going to respond to it. But if they respond, at least according to the adult literature, they're probably, the chances are, and probably in adolescents, once we get more subjects, if you give a single dose, they'll probably go back to where they were before within the next 2 weeks, usually faster. And I worry a lot about that period as a risky period for attempted and completed suicide if it's not monitored closely enough. And so I think it's a really good option, but it requires our health system to do a much better job keeping track of patients than we're currently doing.
Thank you for that. There was a question in the chat by CL. I don't have the full name. Is that person still on? Okay, I'll just read it.
Yeah.
Or can you see that?
Yeah. So I guess the question, I think, and someone correct me if I don't have this right, is in refractory kids, do you usually try, doing I think it's twice a week, ketamine doses for 8 doses, while you try to start a oral agent to see response. Basically, that's kind of what I think that's what I'm doing at the moment, is that essentially I really try not to give kids maintenance treatments. I really the goal is not to have them keep getting ketamine or taking it as a maintenance treatment. And I'm really trying to get them on some other medicine. The other thing I'd add to that is I'm really, really trying to maximize psychotherapy at the same time. I think often my clinical experience is that these kids are accumulating increasing social stresses and problems as they're depressed longer, and they're having a bigger and bigger hill to climb the longer and longer they're depressed for. And so I think it's really important to have really good therapy and have something that they're working with while they're starting to feel better that can help them take advantage of it. Because I feel like oftentimes, even if I get the kid undepressed, they're going back into an academic situation where they missed 2 months of school, and it's really a tough thing, or they have something that, some stress that brought them in. And I think it's really important to also do that in addition to figuring out what the next medicine is, because I kind of intimated that the medications are somewhat more similar than they are different. So I'm not sure I'm going to guess right, or if there's a right guess.
Appreciate that. I'm going to open the floor to folks who have questions. If you feel free to unmute yourself. And anyone in person, Alicia, if you could help with that.
I was just wondering, in the trial that you did, if there was any preparatory therapy work that you did kind of pre-ketamine session.
So I guess I'm not sure this is exactly what you mean, but I think all the kids in the new trial, all the kids were doing like a safety planning session before they get the treatments. We certainly do. We certainly have a talk informing them what to expect in terms of the infusions. We're not like sort of the MDMA assisted psychotherapy where we're doing therapy when they get the ketamine or around that time. I find that honestly, we have often tried to pair the therapy with this kind of after the sessions because of convenience for people. But my experience is that the kids certainly do not have the same ability to remember what happened after the treatments that they do if they're getting the therapy on another day. Think there's a real place to start to look in conditions of how we can use this, how we can use therapy to really enhance the durability of ketamine, both in adolescents and adults. Because I think, again, I haven't emphasized it, but coming in to get a treatment twice a week or once a week indefinitely has a major impact on your life in terms of like where you can go and what you can do and whether you can play sports and whether you can go on vacation when you're an adolescent. And so I think we really need to figure out how can we get the kids to not keep needing this.
So appreciate that point. It is 1:00 and we'll have to let you go and let others go. Thank you very much for your time. Really enjoyed your talk. Thank you so much and take good care.
Okay. Thank you.